Good morning, ladies and gentlemen, and welcome to our Insight seminar today. My name is Cameron from Dovetail. Before we kick off, I would like to acknowledge traditional owners of the land that we're meeting on today and pay respects to elders past, present and emerging. Joining us today, we've got Richard Spence-Thomas, who's the Program Director of the Sunshine Coast Mental Health and Addiction Service. And Richard is going to be presenting on the Great Divide, the journey of integrating mental health and addiction services and future challenges. So for guests joining us online, type your questions, and at the end of the presentation, we'll go to those questions online and then also in the room. So join me in welcoming Richard.
Thank you, Cameron. Thank you, everybody. It's great to be in this Centre of Drug and Alcohol Excellence in Brisbane, and I was asked to present about integration with mental health services and addiction services by Jeff, the director here. And I was a bit reluctant to do so initially because I thought, what am I going to come down from the sunny coast and tell the people of Biella about drug and alcohol or addictions or integration for that matter. But I think there probably is a learning for all of us in terms of this long journey that we've been on in Queensland with integrating addictions and mental health services. I called this talk The Great Divide because as long as I've been practicing clinician, there has seemed to have been a divide between addictions and mental health, and it's something that I think we have struggled to overcome, and we need to keep on this journey. So today I thought I would talk a little bit to contextualise this great divide or this division within treatment services historically in Australia and internationally as well. You know, how we used to view addictions treatment and methodologies to move that towards an integrated model. So I'll briefly talk to that. And I'd then also like to talk about our experience, which may be particularly relevant to people from regional health services who don't have the extensive resources, particularly in addictions, and go through the process that we've been on for the last few years to have closer integration. And also hopefully not terrorise our drug and alcohol clinicians, because when I say integration, I don't mean occupation and taking over addiction services and moulding them into mental health. It's really about valuing the specialty that drug and alcohol clinicians offer us. And I'll also then talk about the challenges that we see ahead of us over the next number of years in continuing this integration journey and really try and bring it down to the consumers and why this is such an important point that we need to account for in our delivery of services. So without further ado, I'll just get the slides up. Thank you. I'd like to just start off by talking to people about the model of drug and alcohol treatment that's traditionally occurred. I'm looking around the room and I think I'm the oldest person here, so maybe you won't even remember these dark days, but when I started training, I'm a clinical psychologist and I've been working in mental health services for a long time. When I started off, it was not at all uncommon to hear people presenting for mental health treatment who had a dual diagnosis be told, oh, well, you've got a really serious alcohol problem, and yes, you've got depression as well, but we can't really help you until you go and address your alcohol problem, and you need to go and see the drug and alcohol service down the road, and here's their number, and when you've sorted that out, come and see us. Now that might seem far-fetched, but that was a very common conversation that happened in treatment services, and vice versa, I suspect, around around treatment areas. And this was referred to as serial treatment. So you take care of, one episode of your condition or your comorbidity, and when that's dealt with, then you can take the next step to get treatment. And I suspect that attitude was certainly around in the 80s and 90s, so it's not that far away that you would hear that type of methodology and referral. And I suspect in some areas you probably still have the snippets of reverting to a serial treatment methodology. The next movement in terms of treating addiction and mental health was what they call parallel treatment. And parallel treatment still co-occurs today, but the idea of parallel treatment is that we're the mental health service and we'll treat your depression or your bipolar. but round the corner or down the street or in the next suburb, there's a drug and alcohol service, and you need to go to them to treat your addiction. And so 2 parallel treatments for these different comorbidities would occur. At its best, it sort of probably merges towards an integrated treatment, and that's that you'd actually have the clinicians from each site maybe talking to each other on occasion. So that was a common sort of evolution in the way treatment was provided for comorbidities. And in the 90s, there was a move internationally to move to what we now call an integrated treatment, where there's a recognition that mental health conditions and addiction conditions are comorbid, interdependent, and both need to be considered conceptually together. And this has led to the term integrated treatment that's been researched internationally for the last 25 years and has mounds of literature on it that we'll talk about briefly today. Just to give some people some ideas of the sort of broad definitions, because what integrated treatment isn't is saying that you can only have one service and everybody has to treat everything, because I think there's a risk in thinking that integrated treatment means that, because all of our health services are increasingly specialised, and you need people to develop specialisation to be really good at it. But integrated treatment really refers to a coordinated care and a seamless care approach, a no wrong door approach. So the World Health definition has been used for a long time as coordinated care and seamless care. In 2010, there was a very good effort by Queensland Health to drag us into an integrated treatment module, and many people in the room might be well aware of the dual diagnosis treatment guidelines, and they have a definition of integration as the coordination of interactions and relationships within and across alcohol and other drug services and mental health services to secure the best possible service system response for a person with dual diagnosis. So it's a fairly broad definition. So why would we make this shift, and why is this an important factor? Well, I'd say 2 things. Firstly, I'd say addiction is a mental health problem. It's not a separate problem. It's not arthritis. It's a mental health problem. And for people in a mental health treatment paradigm to not understand that, I think, is a great problem. It's a problem I still think we've to overcome. And dual diagnosis, those who have serious comorbidities, addiction and mental health concerns, are not a minority group within our population. There's a huge number of studies around this, and we've done some locally on the Sunshine Coast that match all the global findings. But a rough figure to bear in mind is approximately 50% of mental health consumers will also have an addiction problem or a dual diagnosis, a substance problem. The research probably backs up your clinical findings. The more acute that you go to, the higher that rate is. So if you go to a high secure unit or a medium secure unit, you'll probably find 80% of people have a dual diagnosis. And if you go to your average inpatient unit, you'll probably find 50, 60%. And if you go to your community clinic, you'll probably find 40%. So that's the spectrum. It is really, really common, and it needs to be front and center of our mind because of that. And the research about integrated treatment, so this idea of having a seamless and coordinated and easy to access response for dual diagnosis consumers, is pretty clear. I mean, just some of the findings of a large number of research is that it suits consumers, and consumers who have a dual diagnosis are likely to have a life that's more chaotic and complex than the average person. And so going to multiple appointments and multiple geographical venues and keeping multiple relationships going is extremely difficult to them. It's difficult for everybody, but for this group especially so. So consumers like this approach. It's found to reduce hospitalizations. There's studies, numerous studies that have looked at psychological distress and functions and symptomatology that have found integrated approach works better than a serial or a parallel approach. Improvements in independent living and social functioning. Studies on people with psychotic disorders have found that those that receive proper integrated care have reduced symptomatology, reduced use of emergency services, reduced attrition rates and higher treatment compliance rates. And that's a really important one. Treatment's only as good as people engage in it and comply with the treatment and take part of it. So having an integrated approach has a higher compliance rate and high, getting to appointments. One of the questions that's often asked, particularly if I talk about this to a mental health audience, they say, well, why don't drug and alcohol really step up to the plate and start treating people with serious mental illness as well? Why are we putting a lot of emphasis on this on mental health clinicians? Well, this has been quite well studied, so people in this room might be of interest. And the studies have found that the long and short of it is people who do not have a mental health background or mental health training, there's an extensive amount of work that needs to be done to encapsulate the skills and knowledge required to treat mental illness. Whereas for mental health clinicians, there is a small amount of training and can really go a very, very long way, because for people who are trained in treating people with anxiety and mood disorder and psychosis, the skills that they have developed and learnt to do that work, if you think of it as a quiver full of skill sets, we are really trying to just develop one more arrow for that quiver, and that might be the basics of understanding drug and alcohol assessment, doing motivational interviewing, etc., etc. I'll come more to that later. So the studies have shown that a moderate amount of training and ongoing supervision can turn a mental health clinician into a reasonable drug and alcohol therapist with not too much work. So that's why a lot of the focus is on that area. And I also think it's key not to minimize the specialty of our drug and alcohol therapists and clinicians, and we'll talk more about that later. Some more really important findings about dual diagnosis capable services, integrated services, is it reduces the use of admissions. Now, for anybody that's had any dealings with mental health services, and certainly in Queensland today, anything that can reduce admissions is something that's highly sought after and worth investing in. So the findings are pretty clear on that, and that's one of the reasons why we're really keen on developing our services to have a better dual diagnosis capability. Integrated services have been found to have prolonged treatment retention, a higher quality of life for the consumers, and higher satisfaction rates. So Queensland Health has been embarking on this journey of integration for a long time. In 2010, the dual diagnosis guidelines came out, and dual diagnosis coordinators have been employed for probably the last 12 or 13 years in Queensland, and this is the start of an effort to really improve the skill sets and coordination between our drug and alcohol services and our mental health clinicians. It was a central part of the last Queensland Plan for Mental Health. The most recent Sentinel Events Review, where mental health care meets risk, has a whole section on the importance of this treatment for consumers with comorbid conditions. Queensland Health is very much driven by the branch to have increased cooperation and integration between our AODs and mental health services. Some people, particularly those that have been around for a while, might be aware of the Quadrant Model. This model seems so central and established to me in terms of the way we operate as mental health and addiction services that I almost decided not to put it in here today. But I think if you're new to the service, you might not have heard of all of this. There were huge efforts to educate and to illustrate this dual diagnosis movement a decade ago. And one of the things that I think we have done is probably all been a bit guilty of thinking that work was done a decade ago, and everybody that worked in mental health and addictions went through this training, and everybody must know this. But recent work we've been doing has found out that a lot of people, this is new again, and maybe a lesson learned for us that this journey to integration is a marathon, not a sprint, and we need to bring back some of these ideas. So I put the Quadrant Model in here. Effectively, it's a guide to clinicians about who should treat what. So you'll see on the right-hand side, there's the severity of your mental health problem, with severe up the top and mild down the bottom. And down the bottom is the severity of alcohol and drug problems. And, roughly speaking, this can be used as a guide. So, for instance, if you have a very severe drug and alcohol problem and a mild mental health problem, then you should be treated by AODS as indicated in the green, which makes sense. So if your major problem is that you have a heroin addiction, but other than that your mental health is reasonable, AODS is the appropriate place. Whereas up the top of the quadrant model, if you have a very severe mental health problem and no drug and alcohol problem, clearly it's mental health. So the issue is in the middle as to where you should go and what you should be providing treatment to. But effectively, mild levels of mental health and high drug and alcohol problems, it's probably an AODS referral is appropriate. One of the things that most AODS services have, and at least ours does now, is the capability to provide treatment for high prevalence disorders, anxiety and depression within their service. So they can provide that integrated care internally. And for some people, it might mean a co-treatment response with both agencies involved. So the Quadrant Model is a useful guide for us, particularly at a level of level of acute care team referral and 1,300 referrals. So AODS, my history with AODS, I generally come from a mental health background, and I've worked in most types of mental health teams over my career. But I'm a clinical psychologist, and my research has been in addictions. And I actually did a thesis in pathological gambling, and I've had an interest in addiction ever since. And in my private practice, I've largely treated addictions. So I may be a bit of an abnormality, but I'd never worked in our drug and alcohol service. I got the opportunity with Dan Phillips here, who's a Sunny Coast psychologist. Luckily for me, he took a trial to work somewhere else in the service, and I seconded for him for 6 months or so. And I went from a mental health team to AODS. Now, probably like most mental health clinicians, AODS was not integrated into the mental health service. We were separate back then. And I think people had an assumption that AODS was this big service, a bit like mental health. And therefore, if someone had a cannabis problem and they were seeing you, they should go to the AODS service to have that fixed, that serial approach I was talking to. I was quite shocked when I went and worked at AODS because it wasn't a big service. It was, I always sort of say it's 10 men and a donkey work in AODS because mental health is big. Just to give you an idea, and I suspect this is replicated around the regional areas of Queensland and Australia, maybe not so much in the metro centres, but on the sunny coast, we've got roughly 460 odd clinicians in mental health. So it's a big service. We've got a fleet of, we've probably got 60 cars. We've got hubs and offices up and down the Sunshine Coast. We've got hospital wards. It's a big service. AODS probably has, if they're lucky, 20 people in one clinic. We've now got them in 2 clinical areas. So it's a very, very small service. And if you think that service has to treat the addiction issues and be the hub of addiction treatment for a population of 420,000 people, admittedly, there's a lot of NGOs as well. It's a big ask. So the ability of an AODS service, I think, typically to provide dual diagnosis treatment for really complex consumers with mental health issues is very limited. So that's a reality that I think it's important to understand. The other thing that I learned about AODS working there is that their primary business was the opiate treatment program. I hadn't understood that either, and I think most people in mental health services don't quite understand that. But again, I've just given some numbers so that people can understand. And on the Sunshine Coast, they've currently got over 400 people on the opiate treatment program. And that's a huge body of work. As well as that, they've got about 100 people roughly in their counselling and therapy programs, both with the psychologists and the other professionals doing drug and alcohol counselling. And as well as that, they coordinate and broker out counselling and treatment services to NGOs around the coast. As well as that, one of their major functions is to provide secondary consult. So, just from our medical consults, they probably provide about 25 a week doctor-to-doctor consults out to doctors, and as well as that, there's a lot of secondary consult going out from our other clinicians to a wide range of the community, as well as to mental health services, but largely to the hospitals, to pain management clinics, to GPs, to surgeries, to NGOs. So the secondary consult's a big body of work for our AODS team. We did a file audit in 2015 to say, well, what percentage of this AODS population have serious mental illness? And we were surprised. This was a snap-in-time audit, so please don't take this as a rigorous, detailed study, and I don't know how replicable it will be to people's services out there. But at the time of the survey, we looked at every open consumer, and 4% of them had a serious mental health diagnosis. Interestingly, though, 65%, which was higher than the literature would suggest, but 65% had a high prevalence disorder diagnosis of depression, anxiety or such, or a personality disorder. So that's really interesting. So there's a lot of comorbidity, and one could argue that from that, and particularly with the work of the psychologists on the team, that they already are providing quite a level of integrated treatment for mental health, but at that low end rather than the serious mental illness. The other interesting finding that we found when we did this study was that less than 1% of the referrals of that month had come from mental health. And that was interesting. Now, that being said, a lot of the mental health referrals probably don't come directly from mental health, because we were shocked at that finding. And when we looked into it a bit more, we found that quite a lot of people might call our 1300 number, and then after a conversation with the clinicians there, be guided to, your best bet would be to contact our AODS service, and here's the number. And if you call them on Monday, you'll be able to get some assistance for that matter. So we couldn't pick that up. But direct referrals from clinicians to the service were quite low. And the other interesting thing about AODS service, at least in our area, is that their major partner, the other area of health that they have most to do with, wasn't mental health. It was pain management. So the links between the pain management service and the AODS service has grown and is continuing to grow. In fact, one might argue that AODS has more commonality with the pain management service now. Interestingly, our pain management service and many others around the state are now starting to have a larger number of mental health presence in their service as well. So these links are really starting to grow with pain management, and addictions are very close with, but also increasingly mental health. So I see that as a strength. So AODS is a really unique service. So how have we done to take this unique service and integrate it into this broad, large mental health service, and what's it look like so far? We've conceptualized integration in two ways, and I think this is an important and useful way to think about integration. And I think it's important to think about them separately too. So there's structural integration, and that's sort of thinking organizationally. How does this AODS service fit within mental health, and how does it work, and how independent are they or not independent are they? How specialist are they or mainstream are they? And where do they sit? Who's the boss? What's the building look like? So all of these structural things are important and maybe easier to achieve. But I think it's important to divide these two up, because otherwise you can be fooled that you've integrated just because you've joined. So, and the other maybe more complex aspect is clinical integration. How do you get the benefits for your consumers of integrating this specialist service and the specialist skill set, and taking the advantages of that into the mental health service without diminishing the ability of AODS to do the important work that I defined before? And so this is what we call clinical integration. And the way we've gone about it is to have AODS as a specialist service within mental health and addiction services. So in other words, it's no different from our pediatric mental health service or our Evolve service or our older person's mental health service. It's a specialist service, and it's treated like that structurally to avoid the risk of it sort of diminishing its specialty. And so it's a very boring organizational chart, but AODS is one of those boxes down the bottom in the middle, just like all of our other specialist services. So that's how we conceptualize it organizationally. We treat it the same as all the other services. So, we run our service by practice reviews effectively. So once a month, the clinical director and the relevant program director meet with the clinical leads and the operational leads of each of our teams, and we discuss issues and make sure there's a free flow of information and ideas, and we look at all the KPIs, etc., and we've brought AODS into that stream. There's a lot of benefits that can come from this structural integration that are funny things. They're minor, but even having the AODS clinicians and team leaders attend all of our mental health meetings and clinical governance and corporate governance and training and education. So they're now, after 3 years, it's only been 3.5 years for our service. I think we were the last in the state to do this structural integration. So we've found benefits from that. The other surprising benefit we've found is a very purposeful effort to increase our co-location. So we're typically trying to increase addictions presence in our mental health buildings, and we've been lucky on the Sunshine Coast. We've gone through a large population growth, and we're underway in a process of redeveloping and rebuilding our community facilities, and we're very much mindful of having the benefits that addiction specialists bring to having that building, even if they're not directly working in a team, but having them in the building. And we've built a new hub in Maroochydore, and we have some addictions there, and we're planning on growing that over the next year. And in Nambour, which is our main addictions space, the mental health service is next door, and we're about to remove the wall in between. So again, to make it a much more integrated thing, we're finding the integration, having people see each other and close to each other, gives a lot of benefits. It's easy to get secondary consultation, be that in a formal way or an informal way. Hallway conversations are just fantastic. Clinicians are walking down the hall and they see someone for addictions, and they can ask the question, what do you think about this? Where would I send this person? What rehabs are available, etc., etc. And we have an increased uptake in joint training availability, and we can easily access addiction specialists to come to MDTRs, and vice versa. People in the AODS service, if they're seeing somebody and they want to ask some questions of a mental health specialist, they're right there. So this co-location is something I really encourage, and I think you get really good bang for your buck. We have the ability to have AODS easily come to complex case and be involved in complex discussions. Perhaps one of the most exciting developments we've managed to move towards is we've added a addictions rotation for our registrar training program. This is investing for the long term, but we have a HOT team, homeless outreach team, that's located in the same building as our AODS service. So we rotate that placement, so the person does 0.5 in the homeless outreach team and 0.5 in AODS. Of course, there's a natural benefit with that, just because the vast majority of consumers in the HOT team have dual diagnosis issues. So it's a really good time to do this placement. But I would say that this is really a long-term investment, because those that have worked in mental health services will have seen a really broad variety in the skills of our psychiatric workforce in terms of dual diagnosis capability and addictions in general. And that's not just from an understanding and conceptualization of stage of change and the way to engage with people at different stages of changes, although I would say that can be an issue within some areas of psychiatry, but even a more basic understanding of prescribing. And there's a great lack of expertise and use of medications to assist with addictions, and I'm specifically thinking about things like naltrexone and Camprol and antabuse. And I'm really surprised at the diversity within our prescribing population around skill sets of that, which I find interesting, because these, if you conceptualize addiction as a mental health problem, as I do, then you would think that all psychiatrists would really have their hands around that prescribing. And I think it's very varied, and that's not to at all dismiss the huge number of psychiatrists with amazing expertise in this area. But so I see this as an important development for mental health services, and in my view, all registrars then moving to psychiatry should have a very, very solid grounding in the treatment of addiction. You probably can't expect every psychiatrist to be an expert in treating trichotillomania or some sort of variety of obsessive compulsive disorder, or these unique small dissociative disorder, very niche areas of psychiatry. You can't expect them to know all of that, and of course they'll be specialists in that area. But for people not to be able to prescribe widely and understand addictions if you treat mental health conditions, when we've just seen that over 50% of people that you'll be treating are likely to have an addiction, is I think a gap, and it's something we're working towards. I should also say that we get the benefit of all of our registrars that go through this process will be able to prescribe opiates and have a great upskilling in opiates provision as well. So that's another benefit from it. And I don't want to seem like I'm picking on our psychiatry colleagues, because the same exact deficit would apply to all of the professions that work as mental health professionals. Again, it is interesting to me that psychologists, nurses, social workers, OTs, or what have you, often will have a long history and understanding in treating mental illness and see themselves as mental health professionals, but have a blind spot with addictions. So I think that's a context of history, and I don't think we've moved beyond it yet. And I think the integrated movement is the journey we're on to address that girth of skill sets. And one of the great advantages of integration is this cross-pollination. I should explain, for the Sunshine Coast, the addiction services used to sit in community health, so they weren't part of mental health. It made secondments and movements between the services a lot more complex, and we're now increasing the number of secondments between mental health and addictions, and cross-pollination like that is an absolute free win for services in terms of developing staff and developing understanding of each other's operations. So that's been a major win for us in our integration. The AODS has introduced this Making Change group. I think maybe Dan, did you introduce that? Yeah. So I just figured that. I was thinking, how long has that been going? I understand, but it continues to go, and Dan will be pleased to know it goes from strength to strength. This group was an attempt by AODS to address how do we fix, and I'm making this figure up, but I think it was something like 50% of appointments, or was that about right, Dan?
Yeah, the new one.
Yeah, 50% of people that call up and make an appointment, have the triage over the phone, and make an appointment to come and see a drug and alcohol professional in our service. So that means the drug and alcohol clinician has scheduled a time where they're not doing anything else in their busy day, and they're seeing 8 people or whatever, and one of those hour slots, expecting Mr. Smith to turn up, and Mr. Smith doesn't turn up. So that means if they've got 8 people scheduled in to see in on an average day, only 4 of them are going to turn up. So this is not new to our service. This is a challenge everywhere with addictions. People have moments of moving from contemplation to action, and then they're going to go, but by the time the appointment comes 10 days later, they've slid back down into contemplation. So the AODS team developed this Making Change group to try and get people in quicker. So having a regular weekly spot where any new person gets the opportunity. Well, it's going to be 3 weeks until we can see you, but we have a Making Change group on Thursday. You can come and meet the clinicians, find out about treatment options, and see what will work for you. So this has been a great success for our AODS. It also tends to be multidisciplinary, so we have psychologists there, a nurse there as well. So of course, if someone has a mental health concern that needs addressing, we can address that quickly as well. So it's a clever module. So well done, Sunshine Coast AODS. We've managed to increase our postgrad psychologists coming through AODS, and most excitingly for me, perhaps, we've homegrown our first nurse practitioner on the Sunshine Coast, and it's not a mental health nurse pracky, it's a drug and alcohol AODS nurse practitioner, and we've managed to get her working up in Gympie, which is an area of high need for the Sunny Coast. Sunny Coast is reasonably metropolitan down the southern end, but Gympie is 100 kilometres north, and it's a rural regional town centre with huge addiction issues and mental health issues and general low socioeconomic, the problems that come along with low SES status. So having a situation now that if you've got an opiate problem or whatever it may be, you don't have to trek all the way down to our clinics on the Sunny Coast. You can see a nurse practitioner in Gympie, at least for your initial appointment, is a a really good thing for us. So it's exciting development. I think nurse prackies are a really, exciting development for us in both addictions and in mental health. And we've got a couple of very inspiring nurse practitioners working for us, and in an area where the need seems to be relentlessly growing. And this is one of the solutions to provide services, and particularly to areas that are hard to get to if you can't always have your full medical staffing and medical specialty out there. So that all sounds great, and we've done all this and we're integrating, but how do you look at this and say, from a proper measurement and assessment model, how your teams are going and are we integrating? So we've did a project that completed at the beginning of this year, which was to assess our dual diagnosis capability. And there's lots of tools that you can use for that. The one that we used was the dual diagnosis capability tool set. So there's two. There's one that's called dual diagnosis capability in addiction treatment, the DDCAT, and then there's the dual diagnosis capability in mental health. These tools are a psychometric interview and assessment tool that allows you to rate your teams in clinical areas in terms of how your dual diagnosis capability is, or how integrated you are. The DDCAT's been adopted to Australian conditions by the Australian Department of Health and Ageing, and so that was a good tool for us to use, and I recommend it as a tool that's very useful. I'll talk about that a little bit. One thing that the Department of Health and Ageing did is they did a study to look at how do we use this tool? Do we just give it to teams and get them to rate themselves, or do we get an individual assessor out? And this is a study that shows the different ratings that they got with independent assessors versus having it done internally. And as you can see, the pink line above is the independent assessor, and the bottom line is the doing it internally. So long and short of it, it's a tool that values if you have a project officer or somebody that's not from the team doing the assessment, you get a different result. So that was a good learning from them, and we implemented that. And we had an external project officer do this, and they spent half a day out at each one of our services as they did the assessment. Prior to that, they asked for documentation about the service and their model of service. And they also look at the milieu, or the physical settings. That's part of the assessment. What's the waiting room look like? What's on the wall? This type of things. They then, as part of it, they had open-ended interviews with the senior clinicians and managers and support personnel of each team, as well as looking at some of the documentation, appointment schedules, screening forms, etc., to determine how dual diagnosis capable each service was. The DD assessment tools are broken down into a number of themes. So it's program structure. So that's really looking at the organisation itself, how integrated it is, what the mission statement is dual diagnosis part of the mission statement, looks at the program milieu, or the environment, what's it like in the waiting room, what are your displays like, what's your information like, looks at the treatment that's provided, your assessment, your use of readiness for change language, medication, specialisations available within the team, family education, self-help groups, peer support. So all of the treatment, and assesses that on its dual diagnosis readiness. It looks at the continuity of care. And that's really about discharge planning and what happens at the end of service, what happens with relapse prevention. Do you have pathways for people to re-enter treatment? Looks at the staffing, the skills of your staff, your prescribers, your clinicians, the skill set available, the ability for your staff to access a range of specialist skills. And it looks at training. So do your staff all have a dual diagnosis training? Do they understand the basics of dual diagnosis treatment and assessment? And do you have access to people with specialty training? One of the things I liked about it The scoring's really simple. You end up with a score between 1 and 5. Effectively, 1 means that you're not dual diagnosis, you're a serial treatment provider. In other words, you can only provide just addiction services or only provide just mental health services, and so it's not really integrated treatment. And 5 is enhanced dual diagnosis treatment. One of the interesting things is I'm not sure what you're actually aiming for here, so that was good. It's not like 5 is perfect and 1's bad. It really depends what you want your service to achieve, but it just gives you an idea of where they are. And for us, we want most of our services to be around the 3 or above level. So in other words, they're dual diagnosis capable services and they provide integrated treatment. I'll just give a couple of examples. We did the drug and alcohol team, and here's a good example. Their program structure scored low because their focus is all on drug and alcohol. If you read their mission statement, not surprisingly, so that's not good or bad. It's just what you'd expect. But their program milieu was quite high because in their waiting room, they've got not only drug and alcohol brochures and information, they've got some mental health information there too. So that was, the good. Their assessments were good because they assess basic mental health as well as drug and alcohol. The treatment was good, etc., etc. So they got a score of 2.6. Maybe you'd like it a bit better, but you wouldn't expect them to be totally dual diagnosis capable because the Quadrant Model says that they're not going to be doing that pointy end of mental health. And I'll just pick another one that might be interesting. Our cultural healing team, which is our Indigenous health, this was a great learning for us because it actually scored a bit lower than we'd expected. Aboriginal and Torres Strait Islander mental health have a high rate traditionally of comorbid conditions, so we would have expected a higher score of dual diagnosis capability in here. This isn't to be critical of our amazing team, but this is for the management and leadership to look at this and go, okay, we need to put more focus on this team in developing their dual diagnosis capability. So this isn't a pass or fail thing, it's a learning exercise for teams and for management. Another example is our consult liaison team. This was our highest scoring. We did all the teams in the mental health addiction services. So this scored really high, 3.6, so well and truly a dual diagnosis capable service, as you would expect from a consult liaison team. It's a small team for us. We only have 2 consultants, 2 registrars, and I think 3 clinical nurses, or no, CNCs. And they're all highly skilled clinicians. And because of the nature of their work, they've done a fair bit of training in drug and alcohol as well as in mental health, and hence they scored really well. It's also small teams are easy to make changes in. Long and short of this, when we looked at all of our teams, we found that some teams scored quite well in their dual diagnosis capability. For us, it was the CL, our inpatient units, and our MERT and CCU teams. Again, the MERT and CCU, they have a more stable work environment, less throughput, so they're able to they tend to have a large number of senior staff, and they're able to really develop their dual diagnosis skills, and they have done over time, and it showed in this. Our service areas where we need to do a lot more work were particularly our frontline big busy teams like AODS and CCT, and this is where I think I talked about a marathon, not a sprint. For these big busy teams, it comes forth. I think I looked at our ACT team, and probably 50% of the members of that team weren't around when this last great push came to make our services dual diagnosis and to understand the dual diagnosis guidelines and to do all the motivation interviewing training that we offered for many years. So it's this idea of you can't take your eye off the ball on this, and so this assessment tool gave us that message loud and clear and was very useful for us. I'd encourage people who are wanting to ascertain how effective their efforts to provide integrated treatment are to think about using a valid measure to assess it. It really gives you a good opportunity to sit back, look at the results, make decisions and think about it. We, as a result of our work, there were 2 areas that we needed to focus on, and they were staffing and particular access to supervision. It's one thing to provide somebody some motivation interviewing training. It's quite another to then make sure that they have ongoing access to supervision and support to keep those skills alive and well and develop those skills. We also need to provide access to staff who want to extend their fairly basic what I would say is a minimum standard of skill development, which is understanding the basics of dual diagnosis and stage of change and motivation, to start to really develop that, to understand the more complex areas of motivation interviewing, cognitive work, change talk, for those of you who know what I'm talking about. And we need to have those pathways, and I think we've lacked a bit in that. It's training, and that's the I guess the key message. And as a result of this, we've really reinvigorated our training exercise. We're identifying every team. We're making a training module that ensures that the team leaders can sign off that every clinician has undergone specific dual diagnosis training, understands some of the things I've talked about today, has a basic skill to do some motivation interviewing, understands what the motivation interviewing is, how to do it, and perhaps most importantly of all, understand stage of change and can utilize stage of change language. Like, this has slipped off, and I read a lot of notes in my job. I'm reviewing clinical incidents all the time, and I look at this with a keen eye, and I often see we're slipping in areas with this. The real basics, people understanding stage of change. As a mental health clinician myself, when I first discovered stage of change and motivational interviewing, it was the biggest relief, because I'd spent ages before that trying to use my intelligence and training to tell people that if you keep doing that, you'll go blind and it's bad for you or whatever. And then I discovered this great methodology, and all of a sudden it changed things for me as a clinician. It reduced stress. It made me understand that I wasn't responsible for making people change no matter how hard I tried, but I was responsible for applying an evidence-based methodology, thinking about where they were in their journey, not being judgmental, not using language that's likely to make them run away from services rather than to feel services are there for them. So I'm a proponent of it, and I think we need to continue to invest a lot of effort in that area of change readiness, understanding change language, and then leading on to the basic aspects of motivational interviewing. So that was our learning from our study in this area. The other thing we want to do assess is the Quadrant Model that I referred to before. Do our clinicians still understand that? And we're still using it as a guide. I noticed that the dual diagnosis guidelines, I was told the other day by John Riley, who, as you know, is our chief psychiatrist and also is an addiction psychiatrist. So we're in a good space at the moment to really aggressively push this with him at the helm. But they're being rewritten, so I look forward to that. But at the moment, the Quadrant Model is very central. We want to see, do our clinicians understand this? So we made scenarios and we tested our front door teams, our ACT team, AODS Service 1300, and our ED team. And we were quite surprised at the results. The clinicians understood it and they made the correct referral decisions according to the Quadrant Model. So that was great, fantastic. It's working well for us. But then at the same time, what we did find is that a lot of our ACT clinicians were referring low-level drug and alcohol service in real life, not in the exercise, to AODS. And we found that really interesting when people were going to CCT for mental health conditions, but the ACT clinician had seen that they use cannabis or have an alcohol problem. They were referring them to CCT for the mental health, and at the same time doing a separate referral to AODS, which is exactly what we want to avoid. We want to have our basic mental health teams able to do those basic drug and alcohol interventions. So what that made us think is we've got a fair way to go to educate people. And when our DCAT assessment showed that our CCT and our MERTs had quite high level of dual diagnosis capability, why were we still referring to AODS for low-level drug problems? So this type of assessment exercise can give you valuable insights and direct your training resources going forward. So overall, we found that we're pretty much happy that we're on track towards dual diagnosis capability, but we're not there yet. We know what improvements we've got to do, especially with regards to training and the provision of ongoing training and ongoing supervision. I think we fell into the trap 8 years ago of doing lots of training and then, the training's done, tick, let's move on to the next area we want to focus on. So this is such an important area for us. It needs to become part of a regular annual training schedule for every clinician. We think we've managed the structural integration well, albeit maybe that's the easy part. and we need to do ongoing work towards the clinical integration. Although things like the psych-reg rotation, increased secondments, and the physical location and the nurse pracky are some genuine steps towards proper integration that we're pleased with, but there's a long way to go. The other thing that we've became clear to us is that a lot of senior people in the mental health and addiction services, probably around the state, although I won't talk to other services, but I think typically they come from a mental health background. And I guess that's not surprising when you look at the scale of mental health compared to AODS. And I think there's probably a lack of really clear understanding about the importance of this in senior levels of mental health executives and leadership. So doing these sorts of projects and these sorts of talks, I guess, are really useful to educate people in mental health so they can really think in this space. I think for a lot of people it's not the natural focus, and so that's of some benefit, I suspect. Education, I've mentioned plenty, but it's our key focus going forward from here. And I'm pleased we've used the DD-CAT and DD mental health assessment tool because we have a baseline now. So I'm hoping that in another 3 years' time, as we progress with these plans, that we can do it again and hopefully see some improvements in those teams that were lower than we had hoped. So, it's actually a measurement of integration and capability that I think is a valid thing to do. Changes on our horizon. So, beyond the training and education projects that we've already undertaken, and we've got a schedule for the next year to look at that in great detail. We're really focusing on continuing this co-location theme. I think it's really one of the biggest bang for your bucks. It might be hard for you guys in a city area. I mean, I noticed the size of this building, and this is a famed addiction space, but for small regional services, the drug and alcohol service is small, and the integration is a good way to get a good bang for your buck. And for us, we've just on the process of making changes with our court diversion services, and that's a small team of about, I think there's 8 people that are now joined mental health and addictions as well, and we're on the journey to the Court Link program with that service. But we've relocated them into the mental health and addictions hub in Maroochydore. And again, it's already starting to get those linkages that co-location just gives with those addiction specialists. And perhaps the most exciting thing on all of our horizons is the long-awaited integration between AODS and mental health in terms of our computer processes and the joining of the scrapping of ATODS IS and the burning of it, and the entry into a SIMA world. And for anybody like me who's used both, it's a joyful moment. But to have a situation where someone might have a long history of hospital written files in an AODS compactor somewhere, and they come into the front door of a mental health service and there's no ability for them to understand that history, has been a great shame for our services. And I'm so excited about the future of having all of that information from addictions available for SIMA and vice versa. We have all our AODS staff have SIMA access. I don't know if that's standard, but that's the move that we've done, and even that move has been remarkable. So when someone's getting a drug and alcohol assessment through AODS, they'll go onto SIMA and they'll see, hang on a second, this person's case managed, or sometimes they're not told that information. So this is a great opportunity for us to really increase integration and capabilities for our services. I think I've covered this area. So I think that's about it for me, and thank you for listening to my fairly dry speech. I appreciate your time today.
I like the part where you actually knocked down the wall in your integration. That was great. I'll just go to the floor first. Are there any questions from the room here at Biala today for Richard? Because we have got a couple of questions online. Anybody? Okay, we'll go to our online questions. You may not be able to answer all of these.
Oh.
Here's one you might not be able to answer. When will the new dual diagnosis guidelines be finished?
Well, I don't know about finished. I think they're just starting now, so I wouldn't be holding your breath on them. I had the luck of having John Riley visit our services just recently, and we discussed it, and he told me that they're being written now. So if I was a guessing person, I'd probably say within the next 18 months they'll be done. But yeah, if you're holding your breath, read the old ones. And yeah.
All right, next question. Given tobacco use and nicotine addiction is so high in both groups, and morbidity and mortality from this is also very high, how well is this addressed in the services?
That's a great question. Didn't we move the T out of AODS a while ago? I remember it used to be ATODS. Another younger old people will remember ATODS, but now it's AODS. But I can say that from a mental health perspective, and largely thanks to Metro North's Clinical Collaborative, which is a statewide initiative that the Sunshine Coast attend, there has been a massive focus on smoking cessation in mental health services. It's a very hard journey to win. I think it's well overdue. To give people an understanding of what I'm talking about, I think 14% of the Australian population are addicted to nicotine and smoke. Within people with serious mental illness, it's 50% of the population. People with mental illness die, I think, about 18 years younger than the general population. And we all know that smoking is the number one change you can make in your life to live longer. So this is a serious issue. And I think mental health services are tackling it with gusto. You'll probably, I'm not sure where the question comes from, but if you work in a mental health service, you'll be aware that every single consumer now has to be asked about their smoking. And if they do smoke, then they are put on a smoking pathway, which involves offering them interventions for their smoking. I think personally, the biggest thing that we can do is make absolute ease of access to nicotine replacement therapy, because that is a large central key to giving up smoking. People are addicted to nicotine, not to smoking, and I'm going to start being an addiction dweeb if I go on this topic for too long. But nicotine replacement is very, very evidence-based, and if you give people enough nicotine, it's not too hard for them to stop smoking. But that's a lot of nicotine replacement, and for people with heavy addiction, it's often the case of two replacement sources. So, at least patching as one, and secondary, providing a nicotine source that provides a spike in your nicotine levels. So gum or an inhaler if possible, which is the best one of all. So these efforts are really well underway. I think mental health services are aggressively following them. It's a key performance measure now for all mental health services, and with great justification with the seriousness of the health consequences for people with mental illness. And that's not to say there's not more we can do. And I think we probably started this journey quite late, but in the last few years it's been a very big effort and a continued effort. But as I say, I'd like to see more access to nicotine replacements, and I'd like to see more access to and more skill set in our prescribers for using medication for nicotine dependence, because the evidence is coming quite clear now that there's the myth of these medications causing relapse is actually not true. So there's lots of recent studies that have shown that we should be using that more aggressively. It's the number one health issue for our population.